I think we're going to be talking about, we're glad that fusion surgery for stable axial back pain is gone. These technologies are magnitudes better than the best fusion surgery, and they're easy and they're delivered by a needle.
Welcome, everyone. So, as everybody filters in, we will just get started. For those of you who don't know me, I'm Dr. Ariana DeMers. I'm an orthopedic surgeon by training. I'm sports medicine fellowship trained and a regenerative medicine expert by choice. I have integrated orthobiologics into my surgical practice, and then I also built the business of orthobiologics to be able to help other physicians do exactly the same thing and have success. I teach physicians not only ultrasound guided injections, but the ins and outs and nuances of orthobiologics, but also how to add sustainable cash pay regenerative services so that we can all take more time with our patients, earn more money, improve patient outcomes, and reclaim your life without burnout due to the insurance-based volume practice. So I am really excited today to have Dr. Douglas Beall joining us from Oklahoma, right? That's where we are. He is really needs no introduction, but he is the Chief of Services for Comprehensive Specialty Care in Oklahoma City and the head of the Division of Interventional Spine Care at the Spine Fracture Institute. He's Johns Hopkins trained with a Mayo Clinic MSK fellowship, and he really is one of the most published voices in interventional spine care with over 250 peer-reviewed articles, 6 textbooks, and 55 clinical research trials. I don't know how you do it. I don't know how you do all of the amazing things that you do, but man, it is what we didn't put here is you're also one of the founding members of the WIRM conference, which we just had our inaugural World Interventional Regenerative Medicine Institute of Regenerative Medicine meeting in San Francisco. It was, if you didn't go, you should mark your calendars next year. World Institute of Regenerative Medicine, San Francisco, April 2027. Mark them down. It is going to be one not to miss. And you're one of the founding members. So kudos to you. It was amazing to be a part of.
Yeah, thank you. We had our inaugural meeting, and one of the things I was most surprised by it was just this past April. And our next meeting, by the way, is April 1st through 3rd, 2027. And for all of you who are interested in all things regenerative, this is the meeting that's dedicated to it. And one of the things I was most interested in that is inaugural meeting, we had 250 people there, 26 countries represented. And I was absolutely shocked to see the number of people that were interested in and actually doing regenerative medicine.
Yeah. I mean, it is definitely a meeting not to be missed. So with the inaugural meeting, the future is bright for the WIRM. It's really cool. And it's, international feeling. So exciting. This is kind of a more, intimate event where it's just colleagues talking about maybe things that are a little controversial, things that we wouldn't get to hear from a podium, but it's more of that real world kind of nuts and bolts experience. So I have some questions that we're going to be exploring, and I want to kind of start off with the WIRM conference. You really reviewed a remarkable number of emerging disc technologies for interventional spine. So if you had to summarize the current state of affairs for disc regeneration in one sentence, where are we at today?
I'll give you a 2-word description. We're almost there. And a little more on that. We have a combination of various and sundry things. We're regenerating the disc. We have materials that are supporting the disc. We have cells, gels, cross-linking nanotethers, oligonucleotide decoys, genetic therapy for the disc. There's so many different things. We're coming at it from a lot of different avenues. And for the first time, we were really seeing, to roll it back about half a click, there's, I think, 12 or 14 clinical trials that I went through that failed. And our good colleague Aaron Klodny has this great slide that said the disc, a place where lots of good therapies go to die. And that was really true for a while. And I think we finally found a combination, primarily regenerative cells and gel and allografts. So, I did a review of this. It's really the one that's out ahead is the cellular allograft. So the micronized disc allograft. And that has good data. We saw recently at the Aspen meeting in Miami, where Paul Verrills presented the results of the Ascend trial that was done in Australia. Paul practices in Sydney. Just overwhelmingly good results, incredible results to match with some of the other randomized controlled trials and some of the other prospective multi-center single-arm trials. And so this is something I use every day. I use it in 6 patients today. And it just works as a bottom line. And that's reflective by the trial. And these are sham randomized control trials as well. So it's not just like this is, level 5 data. I mean, this is expert opinion. This is level 1 data that's being reported. So, I think that's finally out. It's being used. It's paid for by only 2 Medicare MACs, First Coast and Novitas. So you, with your Noridian, unfortunately, it's the Medicare patients don't have advantage of having that paid. On the other hand, it's not really for Medicare patients in general. It's for people with discogenic back pain. And these are patients between age of 18 and 45. Typically, it's not 65 or over. That's primarily vertebrogenic back pain. And then, we have, in addition to some of the micronized allograft, we have the cellular therapies that are coming along. We have the allogeneic cell therapies or mesoblast and dysgenics coming. And we just finished the trial on the mesoblast. And if that's positive, keeps coming along like we think it will be, probably the prospective time that it will be approved will be about Q2 of 2028. So I'm sure hoping it comes along that fast. I mean, one of the things that's the biggest disadvantages is, I did an interview for our local Fox News a couple months back. And, the thing that struck me as I was listening to the interview was my patient said, "Oh yeah, I'm still doing well. Dr. Beall injected me 9 years ago." I thought, God, it's been 9 years. And that's that same products, the mesoblast product, Rexlemestrocel, so it won't be approved till 2028. And so we're 11 years deep, and I don't know how many hundreds of millions of dollars in with clinical trial and development to get this done. So this is, it's representative of one of the biggest challenges. But I do see that product, and then Discgenics, rebone and putum cell, showed, great significant improvements in pain, function, quality of life, and even changes in disc and disc volume, incredible changes in disc volume, and the results continue to go up. I mean, it's not something that's short-lived. It continues to improve.
So, for decades, our options were like live with it, conservative care, surgery, discectomy, or fusion. Like, why do you think, and we are saying all of a sudden seeing this explosion of interdiscal technology, but as you just said, you've been doing this for, 9 years, 10 years, 11 years. So is it the explosion of new technology, or is it just because we've been so persistent at really pushing this?
I think it's the second thing for sure. I mean, I've been doing basivertebral nerve ablation 13 years now. And with cellular therapy, it goes back even farther than that nine years. So basically, I think now we're a 15-year overnight success. People will say, well, where is all this stuff coming from? And how did we get here? Well, I mean, the answer is it's been building for a long time. We've been doing as recently as this has been approved. When you say the word ablation, people don't think basivertebral nerve ablation. They think, medial branch ablation. They think other ablations, even, lung, heart. There's a lot of different ones, but this is, the purportedly new things have been really brewing for quite some time. And we've got even the cross-linking polymers. We have, the cross-linking nanotethers that have been tested. They were tested in Australia years ago, are just now coming to the point. The brand name for that is Intralink to be able to test and start the trial on it. I mean, we're just starting this Genix phase 3 trial now, and it'll probably be finished in hopefully a year and a half, but not published for about 6 months more, or however long they delay to get it published, and then the approval hopefully will be coming on the ranks and the results of the interim analysis. But you never know. It takes a while. But yeah, these things will all be out. I mean, the thing that I wish the most out of everything that I do is that I would just have easy, unfettered access to the things that I have already, and that I weren't governed by the rules of insurance coverage or FDA approval. I mean, we've seen that these cellular therapies, to say they're safe is not right. You would have to say they're extremely safe to be accurate. I mean, rare to see an SAE, much less a persistent SAE. I can't even remember one. So these are very safe. I would just like to be able to use them how we see fit. And I think we've seen zero for cervical, right? It's all been lumbar. We've seen zero for basivertebral nerve ablation outside the lumbar spine, even though the mid-thoracic spine has lots of problems with degenerative end plate changes. So, there are barriers, but most are somewhat artificial, regulatory and insurance. The barriers really are not, our capability of doing this. But I mean, so I got a chance to address Blue Cross. And let me tell you what I told them compared to for basivertebral nerve ablation before our Blue Cross, which is HCSC, covers Oklahoma, Texas, parts of Montana, New Mexico. It's big Blue Cross, to compare it. So I told them, compared to spinal fusion, basivertebral nerve ablation is only viable competitor. This technology is 2 to 2.5 times better. It's 5 times cheaper, no incision, no downstream and adjacent segment disease, essentially no recovery, and it appears to be permanent or durable. I told them I have no idea why you're not covering this.
It's so frustrating, right? So, based on this, and you're exactly right, you have a lot of tools in your tool belt that, the general physicians don't have access to. So if we had to grade what everybody has access to, and we can include cash-based, in PRP, BMC, where do you grade the evidence and real-world clinical utility for what is available outside of clinical trials in the real world? Where do you kind of put these? Where do you rank them?
Well, PRP probably has the most data. Intradiscal PRP, is okay for data. There's not just a landslide of blinded randomized control trials with PRP, nor should we expect there to be these trials. I mean, most of the really good trials are industry sponsored, bottom line. I mean, and yeah, sure. I mean, it's profit motivated, and what it probably is okay to be profit motivated in terms of making a successful product that you can deliver to people. But I think PRP more than BMAC, but these are clearly beneficial, and they're clearly better than just, we did a trial on intradiscal injections of corticosteroids, and it works really well, especially when the patient has modic 1 changes. And this is a technique that's employed in Europe sometimes, and it's definitely a bridge to other therapies. We typically didn't do anything. It's like my buddy from Jersey said, it's 3 whacks on the back, meaning 3 epidural injections that weren't designed for back pain, followed by fusion surgery, which is permanent with a predictable adjacent segment disease rate leading to additional surgery. Call it back surgery because you keep coming back, right? I mean, that's one of the things that we know to the percent. But I think the alternate for this, for somebody that has a practice and doesn't really know how to treat back pain, first we just separated into anterior and posterior column. Anterior column, pain with forward bending, pain with flexion, pain with sitting, as opposed to posterior column, which is pain with extension, pain with twisting, often pain with getting out of a chair. And these are things that need to be separated. I saw 3 patients today that were good candidates, clear anterior column pain, that had undergone medial branch RF, and it wasn't even close. The last guy I saw was 35, a disc injury about 7 years ago, had an obvious modified Fearman grade 4 to 5, at 5'1". All the other discs were normal. Facets were normal, had Modic 1 chains around it. I mean, and he was getting epidural injections and medial branch blocks and rhizotomies. It's not even in the right zip code, right? I mean, that is not the Willie Sutton of why this guy has back pain, right? And I think we need to shift our diagnosis, make the right diagnosis, realize that half the back pain at least is coming from the anterior column, and do something in the anterior column. And if you don't know how to do it, learn how to do a disc injection, learn how to do, and I'd rather put 10 milligrams of dexamethasone and a couple of cc's of 2 or 4% preservative-free lidocaine, which is the recipe, by the way, and see what happens. That is my discogram, 62290, and I wish I had a 62292, but that's my discogram. So you put this into the disc with a little bit of contrast, and you can scan it, CT scan it afterwards. It doesn't go anywhere except the disc, and the person's pain goes away. So where's the pain coming from? The disc. How sure are you? 100%. So, and this is something where you don't have to do provocative discography and I haven't done that in forever, and I won't do it because it's brutal. And so if you cause pain or take the pain away, the result is the same. You know where the pain is coming from, and taking it away, there's nothing like watching a patient who's had pain for 20 years stand up and say, oh my gosh, the pain is gone. I can't believe it. So that also not only is a diagnostic of diagnostic importance, it is something that is potentially therapeutic.
Yeah, you say something really interesting and it really resonates with me. And so I think it is worth repeating, and I'm sure most people on this podcast are clear how to get the right diagnosis. But if you had to leave people with that pearl of how do you differentiate anterior column versus posterior column, I think that's really important to get. Number one is to get the right diagnosis, because if you treat the wrong diagnosis, clearly it's not going to work, and then it makes a bad name for the treatment. It makes a bad name for treating back problems, when I think we're better than that. What would you tell people, like, is that pearl to take home and be able to knock it out of the park on Monday?
So, I have a lecture I just finished. It's, what to treat when, and in regard to the disc in-plate anterior column. And it's fairly complicated because it involves physical exam, it involves disc chemistry and single voxel spectroscopy with MRI, it involves motion of the spine with continuous fluoroscopic motion, but it also involves things like MRI, physical exam. And I think the basic division of anterior column versus posterior column is really pretty straightforward. Let me give you an example. So if you have discogenic or vertebrogenic back pain, the heat map of that back pain will be right in the middle of your back, not paramedian. Paramedian tends to be facet, SI joint, things like that. So if you have somebody with midline back pain, that's let's make them less than 50. So really ideal for discogenic or vertebrogenic back pain, less than 50. They have a positive sustained hip flexion test, meaning you lay on your back, you put your legs up and you lower them down slowly. And if that causes pain, that's a positive sustained hip flexion test. And an MRI that has a disc that's degenerated of any degree. So Mike DePalma did work on all this and said that has a positive predictive value of 94% for anterior column pain. And I, functionally, absolutely, I agree with that. Maybe there's occasional red herrings or things, one-offs that mimic that, but boy, not very often. I mean, I don't often inject a disc with anesthetic and not have the pain go away.
Yeah,
I did.
so important.
I don't know how many patients today. I mean, maybe 9, 10 that I did that, and they were all zeros. And it's one of those things that I want people to experience that. You see what you look for what you know, and if you don't focus on the anterior column, you just miss it. But that is where the money is in terms of back pain. That's where most of the back pain originates from. And it's often treated with fusion. And I've said over and over again that stable axial back pain should not be treated with spinal fusion. I think, period. There are exceptions to be made, of course. I mean, Tim, you mentioned the lack of good options. And I mean, people are doing epidural injections for back pain. Epidural injections are for radicular pain. So, but if you don't have the capability of doing anything, that's what would happen is somebody would get a fusion. And it basically was 50-50 whether somebody improved or not. And I think most of the surgeons that I work with and around don't fuse people with stable axial back pain. They fuse for scoliosis and spondylolisthesis or some other type of instability, scoli, spondy, or lateral spondy, anterior posterior spondy, or vertical instability of the disc. So, I mean, anything other than that, it should really be treated with an ablative, meaning BDN, or regenerative, meaning cellular therapy, or micronized allograft, or a structural treatment like a gel. And we're evaluating now. We have a clinical trial going on for hydrofill. It's a hydrogel, PVA, PVP, and PEG. It provides structural support. We've done the hysteresis curves on that, so we know it provides structural support. But it just works. And probably the secret sauce of that is, here's some inside baseball, right? Inside sauce of the hydrogel is probably anti-inflammatory. So we saw cases of, sometimes people don't get a lot of gel in, still work pretty well. Sometimes the gel would expulse a little bit. And, we had early cases where we had to remove it because we were unfamiliar with who to treat, who not to treat. And it's very easy to do. But it's, you don't like that to happen. You want it to stay where you put it and have it be. But, we took some of it out, left some behind. And strikingly, these patients still did well. And so recently we tested this in an animal model and found that it was strongly anti-inflammatory. And this goes for the N-isopropyl acrylamide, dimethyl acrylamide gels, as well as the polyvinyl pyrrolidone and polyvinyl alcohol hydrogels. Both of those classes of gels appear to be anti-inflammatory as well. And they can carry cells. They're vacuolated and they can carry cells, especially, I was looking at a histophotomicrograph of a acrylamide gel, and it has these little holes in there. And this has been tested in the bioreactor. If you put this into a disc and put the disc in a bioreactor, the nucleus pulposus cells continue to proliferate. They continue to grow and expand, and has an anti-inflammatory action to it. And it's one of those things that, I never thought I'd see. I thought the whole time the MOA of this would be it's a fix-a-flat for the disc, and you put it back up, but it is, apparently not. So yeah. The more I know, the less I know.
Cool, right? You just got to keep digging. So what do you think if you had axial back pain today,
yeah,
and you were like, okay, I got my pick of the litter, I can basically have anything, what would be your go-to?
Kind of depends on what it looks like. I mean, and how extensive it is. Let me just give you some really real world approaches, algorithms. So, I would like to think that I would have discogenic back pain, because that would be mainly in the 18 to 45 range.
Right.
Yeah. Wishful thinking, right? Well,
well, I mean, I don't know. Maybe it's the cells, right?
Yeah, exactly. Yeah, that's right. Let's just pretend that I have discogenic back pain. All right, we'll okay. Pretend that. So if I have discogenic back pain, I would want to come in and be evaluated, have an MRI, physical examination, and all those boxes that I mentioned would be checked appropriately. I would really hope to see somebody that would say, well, okay, we really need to inject your disc, confirm that your pain goes away. And, it's not unusual for people like this to have relief for 6 months to a year or more. And that's exactly what I find. And we've written about it, and that's just the way it is. And if you do come back, there are worse things in life than an injection a year if it helps you. And I think I'd be satisfied with that. If it doesn't, let's do a regenerative injection. We have access to Viadisc, which is micronized allograft. I'm sure, sir, your insurance doesn't pay for it, or if it sometimes does, we get one-off commercial payers and federal payers, Medicare. And, I would hope that I would have access to the Mesoblast rexlemestrocell or Dysgenix rebonoputum cell. And parenthetically, I'm not really quite sure how these things get named, but that's what they're called. And these technologies are magnitudes better than the best fusion surgery. And they're easy, and they're delivered by a needle under typically moderate sedation. I give people antibiotics whenever I inject the disc, usually gram Ancef 80 of Gent or 600 clindamycin when they're allergic to something, or if they're allergic to any of that, then gram or more Vanc based on weight. And, it's something that's very easy. So let's roll that back and make it discogenic back pain. Same visit, same diagnostic, same option. And typically, if I had vertebrogenic back pain and I had, it doesn't really come as a one-off very often. Let's say this is not a one disc vertebrogenic back pain, a multiple disc. Well, it's easy to do basivertebral nerve ablation. And and the outcomes for basivertebral nerve ablation, I kind of sum up all the existing literature as an amalgam, and I say, you have a 75% responder rate with BVN ablation. If you're a responder, your average pain reduction is 75%, and it appears to be permanent or at least durable. That's what I tell them, and I think that's pretty good. And and you can also do multiple levels, and that makes a big advantage. You can only do one disc with a lot of the. And the problem with doing one disc is that you're painted into a box. You can only do one disc with VIDIS because that's what Medicare says. You know what evidence that's based on? Nothing. Zero. Every single trial has been one or two discs with VIDIS. Except one that was with Medicare patients, we did up to 3 discs. So we're now limited to just do one disc by Medicare, which is capricious, arbitrary, and unsupported. But and the other cellular therapies, we're just testing one disc. Sometimes L3 to S1, and it needs to be the whole lumbar spine. If you're going to test lumbar, test lumbar. There's no reason to test L3 to S1, as we found out from basivertebral nerve ablation that typically is only approved by insurance companies from L3 to S1. So, what do you do when it's mid-thoracic spine, lower thoracic, thoracolumbar junction, upper lumbar spine, which is really common? So, we've got some work to do to overcome some of the often artificial insurance barriers. And so, if I could roll back, I want to finish the scenario. If I have just one level of degenerative disc disease with this just trashed, modified Vertebral grade 8 with modic changes and erosions, or 2 of those, that would be really good for hydrogel. So hydrogel really achieves its niche with modified Vertebral grade 5 through 8, and the scale only goes to 8, as you know. So moderate degeneration to moderate to severely degenerated that's really the territory of hydrogel. And really, there's nothing else. The cellular therapies are not really used in the very degenerated. And intraleak, the cross-linking nanotether is going to be used to modified Vertebral grade 3 through 6, so mild to moderate. And most of these, some of the, Spine Biopharma had a amino acid anti-inflammatory that was just used in the same category. The other allogeneic research is really done in that middle category. So there's really the gels occupy the very degenerated category.
And what if your friend or your colleague that was treating you said, "Hey, I want to do, your own stuff. I want to do autologous." Yeah. What would you tell them?
Yeah, I'd be fine with that. I mean, you could do a stepwise fashion. You could do a PRP first, then BMAC second, or you could start out with BMAC. I think the literature kind of favors BMAC more than PRP. I look at it as stepwise fashion. So I did a kind of an analysis of all of the allogeneic and autologous literature. I based it on a great article by Jordy Scholl. And so I based it on that. And really what I found was no difference. I found no difference, really. I mean, it tended to improve the back pain by, 43, 44 points in VAS and about, 31 to 32 points in ODI. And they were almost identical. And that kind of surprised me because I always thought the allogeneic may do a little bit better, but I am biased because that's what I see. I see the allogeneic. There's not a whole lot of research being done with autologous stuff, mainly because it's not industry supported. primarily, not industry supported. You know, there are industry supported autologous trials, but just not nearly as many.
No. Now, we're still walking down that, right? And we're still walking, and let's say your insurance doesn't cover any of the options. And from a cost perspective, in your regular patient that wants durable results, and what do you tell them? What is the most cost effective? Maybe there's some hydrogels and some things that are available but not covered.
Yeah, not covered. I mean, these aren't even available. I can't. There's both hydrogels I mentioned. One is in PMA trial, but we're doing it now. The other one is called Integrial, and that's made by a company called Orthosun out of Oxford, England. And that's not available at all. I mean, it's just been done in animals. We're going to start our first early feasibility trial, hopefully sometime very soon. I kind of expect it at the beginning of next year. I'd like it even sooner than that if we can get it. It's got great safety data. It's got great phase 1 data, and this is something I really believe in. You put it in a tissue reactor, you put it in the disc, and the disc comes out healthier than it was before. So this is pretty compelling data. But yeah, I would probably go for the biggest bang for the buck. I'd probably go with PRP.
Okay.
Yeah. To start out with, Anu Navani did a great article on PRP and in the disc, and kind of looked at an analysis of the various pieces of literature that's in there, and it works. I don't think it works quite as well and quite as long as cellular therapy. And the question is, how long is it compared to gels? I have no idea, to be honest with you. I mean, the gels could potentially be the same, at least durable or permanent. And most of these things are. I mean, if you take somebody, like take a knucklehead 30-year-old male with, really good discs that has he's driving his four-wheeler too fast, or, jumps off something really high and injures himself. I mean, that was a bad disc that was once a good disc. So you can always re-injure a disc, even if it's regenerated and healed pretty well, because disc can and will heal, but it's no guarantee in life. There's no death and taxes guarantee with the regenerative stuff. But the good thing about it is as we saw in the VAST trial, once you treat somebody, they can be retreated. And I'm going to give you this is an approximation, but if you look out 3 years, 85% of those people are still doing well. And the 15% of people that are not doing well can be re-injected and typically do well as they did the first time, which is pretty darn well.
That's pretty compelling. Now, at the WIRM inaugural event, there was a lot of conversation about intraosseous vertebral treatments. Where do you stand on that? We've talked a lot about injecting a disc, but there was some compelling discussion about intraosseous vertebral injection of regenerative therapies.
The favorite son of Sudhir Dewan.
Yes,
the
correct.
subchondral injection. Well, Sudhir is brilliant, but he borrowed that idea from Philippe Hernegal, which is also, he's older than Sudhir and been in practice longer. So he's orthopedic surgeon that tried this for joints and found that it decreased the rate of total joint arthroplasty by a lot. So, and very compelling. And Philippe is this guy that has like data, like 30-year follow-up. I mean, it's ridiculous data. I mean, ridiculously good. I mean, and I'm a believer. I mean, you can look at the scanning EMs of cells crossing the end plate to the old Volvo Research Award from the 90s that showed if you radio label something in the disc with a nuclear radio label, you find it later in the end plate. I mean, this is a whole scenario where the hypoxic region of the bone marrow adjacent to the end plate, and that's where the nerves from the basivertebral nerve go. I mean, this is an active area. I mean, it's not the Gobi Desert. I mean, you find cells in there. You find cells if you harvest from that area. The original VAST product, the VAST trial, the Viadisc, was cells harvested precisely from that area because they were rich in stem cells with a certain degree of stemness, medicinal signaling cells. So, I really believe in the interaction between that, the cartilaginous end plate, and, the type 1 and type 2 collagens that's present in the annulus fibrosus and in the nucleus. So I think that if you treat the annulus and the nucleus with something, regenerative cellular therapy, for example, because, people have this idea that annular tears just happen, you can see them and they're there, and if you don't see them, they're not there. Look, if you have modified Fairman grade 5 black disc, no height loss, and you jet contrast into it, it's diffuse annular tearing. It just is. There's annular tears everywhere. So the first part of disc degeneration, the very first sign of diminution of the signal of the disc, you have annular tears everywhere. Not everywhere, but if their annular tears are present, especially when it gets grade 3, and then more in grade 4, and a lot in grade 5, and diffuse everywhere in grade 6. So I think injecting in the disc, taking care of the disc augmentation, nucleus annulus, and injecting subchondrally in the end plate. I mean, I'm a believer in that. And what data do we have? Well, we just submitted a paper, just a few patients, not very many patients, but it was kind of a matched cohort trial, Sudir and another author that had far less patients, but the results were fantastic. So I think there's something to this. I mean, is the subchondral regenerative treatments did it with BMAC, is this treating discogenic or vertebrogenic back pain? I would have to say it's treating, yes, one of those or both of those. And I don't know. I mean, it could be a regenerative treatment for degenerative end plate changes, because anytime you inject subchondrally, you have erosions of that really go erode into the vertebral body, and that's where you find the great preponderance of the neural growth of the BVN. That's where it arborizes the greatest. So it probably treats both, probably treats that. And, it's based on Hernegal's original work. And we're publishing this. Look, it's not a magnum opus, nor is it a product for the New England Journal or the Lancet, but, at least it's going to be data, and it's kind of the first data that I'm aware of this technique. And, I'm a fan because not only does it make intellectual sense to me, I've seen the preliminary results, and they're very impressive.
Yeah, that was for me really interesting and fascinating. And the first time that I kind of was able to think about this in the same way that we think about joint,
Yes.
chondral, and intra-articular. I mean, it's a correlate, right?
Yeah.
So super interesting to be able to have that translatory, what we know in science in the interventional spine versus the
The
joint.
knees,
Yeah.
right?
It's
I mean,
super interesting. And I think we can all learn from each other and not be so siloed in our thinking and say, okay, like this is working in this environment that looks really similar to what we work on. Maybe we should consider this. So
absolutely. I don't think you really have to have a new idea. You can go around stealing other ideas and applying them elsewhere.
Gently borrowing, right? Gently
Your
borrowing.
whole career. You can do that the whole career. But that's right. I mean, I saw that it showed me that subchondral technique, and I saw, I mean, that's the same one that Philippe Hernegal did, and we borrow this from subchondroplasties and treatments of knee cartilage, right? I mean, this is very similar stuff.
Yeah. So tell me this, this is really exciting, and I do think this is the new frontier, and I do think that there's going to be some, detractors, but despite all the excitement, what do you think is there a problem that we haven't really solved yet?
Yeah, so I'm going to back up a little bit. I think the problem that we haven't really solved is kind of how to use specifically for regenerative. And then I'm going to give you a couple of other ones I think are really unsolved problems for the spine. I think for regenerative, we don't really know how to use these things yet. So we said, oh, cellular therapy, modified Fairman grades 3 through 6, definitely, because that's based on my non-randomized, non-placebo controlled study of my own opinion, which may be uninformed. So, and we looked at the VAST trial. And we didn't have a core lab, and so it's like the line from Animal House. You effed up. You trusted us, and so we trusted the people to only do it modified Fairman grade 3 through 6. but we had a full cohort of 7s and 8s in there, just left it up to the investigator. And based compared to 3 through 6, they did about the same. And modified primo grade 8 does not quite as well as 3 through 7, but it does pretty darn well. It's hard to find you can't find significant difference in the trial when we didn't. And comparatively, it just did slightly worse, not a whole lot worse. So we don't know how to use these things yet. I was talking about cells and gel. Putting something in like a gel that has, a biomaterial that changes the hysteresis curves, that provides structural support along with cells that will live and give it a carrier, so where you can actually put it in and have the thing live. The problem with the cellular life is that you inject it into a disc, and it is the Gobi Desert. It's a harsh environment. And if you just had a nice hotel with the gel for it to live in for a while, it would make more growth factors, and it would have better signaling, and maybe even live, maybe even rejuvenate some of the nucleus pulposus cells. What we've seen, and I'm going to take a deviation a little bit, what we've seen from the DiscCure trial is that you can put an electronic lead in the disc, and it does regenerate the disc. It doesn't regenerate it completely, but I have case after case of signal improvement, and the high intensity zone that's now gone. The disc looks healed. In an animal porcine model, it can regenerate it completely. So this is another area of electrical regenerative medicine. And this is completely different mechanism of treatment, but we're in clinical trial now. Not we as in not me, but this is being done in Canada as a pilot trial. Hopefully we'll be able to get that going soon. But I think the unsolved problems generally in spine, here you go. Minimally invasive ways to fix an isthmic pars defect in a young person. You can put screws in. It's not a great trial. The pars interarticularis tends to be really thin. You don't often get good purchase. Pars can start to erode the joint. You can have it proud, the ventral side, and it can irritate the nerve. And then, decompression, somewhere between a surgical decompression and a minimally invasive lumbar decompression, or mild. Somewhere in between, somewhere you can actually remove more tissue, similar, to an endoscopic. And not only decompression, but a lot of the endoscopic work is just not reimbursed. So that could be improved a whole bunch for decompression and reimbursement. And then, what I'd like to see is whenever somebody does have instability, I would like to see the ability to do a PERC front back fixation without having to do a big anterior approach and without doing a big posterior approach. There's techniques that you can do put an interspinous fusion device, and you put it with a little bit of declination to get over the top of the hypertrophy facet. Then you move that incision up, and you do a transcambon anterior fusion stabilization for people with bad spondylosis stenosis that aren't really good surgical candidates. There's nothing to do that with. It's you kind of have to cobble these things together. So those are we have plenty of challenges. There's plenty of room for innovation here. So for those of people coming along that say they want to innovate, that are new to their career, it's a wide open field still.
Yeah, it's so exciting. So, when we're at the WIRM conference 5 years from now, what do you think we're going to be talking about as like the passe thing? Like, oh my gosh, can you believe we actually did that?
What I think? I think we're going to be talking about, we're glad that fusion surgery for stable axial back pain is gone. I think we'll be talking about that. And some of the things that have come up. I remember back when RMI made this thing called a new disc. It was an expandable gel, and we had something called gel sticks. These are things that, like the Fernstrom ball. You remember that from Ulf Fernstrom? It was this like ball bearing that you would put in the disc.
We had the same thing in the knee, though. We had this inner space. It was like metal, and you stuffed it in there, and clearly that didn't go so hot.
Yeah.
So, yeah, I hear you.
But there are also other things that I don't really understand, like DASCOR had a nucleus replacement. PercuDisc has a nucleus replacement. There's a thing called BioDisc that was a protein hydrogel. And these things actually have pretty good data in terms of pain and functional improvement, but they tended to expulse. They tended to pop out. And, so some of the things that I think we will look back and say, we could have really tweaked this a little bit and improved it. Let me give a good example. And here's kind of some secret sauce stuff for hydrofill. So I remember seeing hydrofill a long time ago. It wasn't called hydrofill. And, I talked to David Wilson from Oxford, and he was telling me about, it's kind of it's hard, it's medium hard, like overcooked linguine, and you just push it in the disc. And he was trying to explain how he would push this hydrofill into the disc, and it wasn't flowable. You couldn't really inject it. You'd have to open it up and push it in there a little bit. And that's the problem, because when you open the annulus, everything tends to come out the hole that you made. And so, it was years later, and a buddy of mine that I used to work with in Baltimore called me up and said, hey, my friend that is on the board of directors for University of Maryland has this product, is something, I think it's something you can use. And it was hydrofill. And what they'd done is they added polyethylene glycol as kind of a emulsifying agent or excipient, and you'd be able to heat it up to 65 degrees C or more, and it would take this gel that was the same tactile sensation as kind of a medium soft pencil eraser, kind of feels a little bit like nucleus pulposus, and you would make it a liquid, and you could put it in through a needle, and then it would cool down and form. It would fill all the cracks and crevices, and that's hydrofill. It was the same stuff that a guy named Tony Lohman, who's the provost, he was out of Pennsylvania, and he was able to formulate this to be able to make it an injectable, and so kind of resurrected this and bought the rights from Synthes, changed the formulation. And all it took was just a little change, and now it's a very usable product, something that was like some of these other legacy products that weren't very usable, that tended to expulse, and changed it to something that you inject and it hardens and, fills the cracks and crevices and holds it in place.
Yeah, so good. So we're gonna fire away. We're gonna do
Yeah.
6 quick fire questions, and you just have whatever your answer comes, you just tell me. So what is the most underrated disc technology right now?
Underrated disc technology, I have to go with hydrogels, because those get like 78, 88% proven in pain and function in our MATS cohort trial. And people don't recognize or realize that even. I mean, these are over the center field fence in terms of pain and functional improvements.
Most overhyped technology right now?
That's lumbar fusion. It is. I had a webinar pop up on my email just about a couple of hours ago talking about lumbar fusion for back pain. And I mean, I don't buy that. I can't buy off on that. No way.
Biggest surprise from the technologies you reviewed at WIRM?
I think the biggest surprise is, in general, is the number of people that were doing regenerative medicine. So I think in terms of tech, I would have to say the subchondral injection we talked about and the data that was shown, and also the molecular imaging. That kind of, I really was impressed by that. Oh, the imaging of pain.
Yeah, that was really interesting.
Right.
Molecular imaging of pain. I
Yeah.
think that you just answered number 4, which is that
Yeah.
technology you're watching really closely. I
Yeah.
think
And
it's
this is a sodium channel blocking device, a molecule that is attached to a FTG, fluorine FTG, and this is something that you can label. It attaches to the sodium channels, which are pain generators in the peripheral nerves, and you could do PET MRI or PET CT and identify this. And this is something we've been able to wanting to try to image pain, and they're not there's not only one company doing this. It's primarily PET driven, so positron emission tomography driven. And this is something that, given the right monoclonal antibody attached to fluorine or some type of FDG radio tracer, you can image whatever you want to. And so this is very impressive. I think this is something that's going to be utilized highly in the future.
What's one study you wish someone would fund tomorrow?
I would say something for the cervical spine. The lumbar is 2/3, cervical is 1/3, and thoracic is the other third. And it's like, thoracic's 5 to 8%, but and look, I deal with cervical pain every day. And, we have cervical discogenic pain all the time. We have zero for it. I don't have any trials for it. I don't have any, I have PRP and BMAC, but there's no funded trials for it. I mean, I really wish somebody would come out with something for the cervical spine and maybe extrapolate some of the successes in the lumbar spine, like BVNA, to the thoracic spine.
What's one thing every spine physician should learn in the next 5 years?
You have to be able to access the disc, period. Yeah, I mean, I don't think accessing the subchondral end plate is a big deal. Most people know how to do kyphoplasty or vertebral augmentation, or do a transpedicular access for a pedicle screw, or BVNA. I think that skill set is fairly replete, at least transpedicular is. But to access the disc, the only people who know how to do it are the old people and the young people. And there's the middle people that never learned to do it in residency because discography was out of favor. And there was no focus on injecting the disc or anything around it because you had no treatment for it. Those are they're in no man's land now. So be able to access the cervical disc from the front, the lumbar through the transcamen approach, and also the thoracic spine from the transcamen approach. Hopefully, we'll be able to have treatments for all three of these segments of the spine.
Awesome. Awesome. Well, that was if someone didn't learn something today, you were either asleep or not present. So good. As we go forward, why do these conversations matter, right? Because not only is clinical excellence really important, but it's not enough. And so our patients have changed. Our patient expectations and outcomes have changed. Our economics are changing significantly. Clearly, training hasn't changed, but great physicians were never taught about business, never taught how to do clinical trials, how to fund clinical trials, how to think about economically what we're doing and what is biggest bang for your buck. How do you get these treatments to your patients? And so it's really hard to market for your patients and tell them what you do and make sure that you reach them and implement these regenerative therapies that aren't covered by insurance-based care.
On the bright side of things, just to add to that, if you don't mind,
Yeah.
is, I was never trained on any of that either. I mean, like zero. So, there's hope.
So
I think
it's a learnable skill, right?
it's hope. I think if I can learn it, anybody can learn it. And, I wasn't trained on any of the stuff we talked about tonight, and the financial stuff, zero. But it is definitely a learnable skill for sure.
Absolutely. And that's what I tell everybody in our programs is, just because we didn't learn it doesn't mean that we don't know how to learn. We've proven in medicine that we know how to learn vast amounts of knowledge. We just haven't gone to that school. We haven't read that book yet. And so that's the awareness, and there is a pathway to this journey, and I am here as a guide to kind of help guide you through this awareness. We now have a readiness assessment, so that's our next step, and then we have a number of different pathways to help physicians learn how to do this. And so a question that I always hear is like, I know where medicine's going. This is really exciting, but I don't know how to get there. I don't know how to get from my insurance-based clinic that I'm in right now to all these really cool things that you guys are all talking about. Like, how the heck do we get there? And so if that's you, you're not behind, you're right on time, you just need a roadmap. And that's what we're gonna just show you to right now for the next couple of minutes and show you the path forward. So what do we take away from this episode, right? Number one, we want to rank the evidence, not just the hype or not what you've been doing for the last 25 years. These technologies are worth considering. I think number two is that there's some ready for prime time right now. And what really stuck out to me is safety. These are really safe therapies for our patients. Number three, we have to do a good job on physical exam. And we have to make sure we understand what our patient's symptoms and goals are, not just treating the MRI, right? That physical exam and getting the diagnosis right is really important. And then number 4, separating that innovation from marketing hype, right? You are clearly on that path of evaluating very, very clearly the innovation that's happening right now and really putting a scientific lens and eye to that. And that number 1 is why you're here. Number 2, that is to be commended and, if at all possible, replicated with all of us. We're all clinician scientists, and it makes it easier when the industry is sponsoring. It really does. When the industry isn't sponsoring, I still believe that there is a responsibility for us to collect data, even if it's on a spreadsheet, know what we're doing, how we're doing it, how our patient outcomes are doing. I think we shouldn't not know what we're doing for our patients. So I'm going to just urge everybody to please, please, please collect data. I will share with you some physicians that took the path, right? They got new revenue off the treadmill. They have better outcomes and happier patients for these regenerative medicine, cash-based practices. And finally, a practice that actually fits my life. And that's really important as well. Not only do we have these great technologies, sometimes when we implement these great technologies, we're able to regain that passion, regain our life, our time back because of these outcomes. We get better outcomes, happier patients, and they don't come back. These are durable results. So I'm just going to put this here before we finish. This is a QR code if you are interested in how to implement so that you can provide these regenerative type therapies for your patients. Please just take the quiz. This is a 3-minute assessment and it pinpoints your biggest bottlenecks and hurdles, and then you can get your personalized path forward. So our ecosystem at Business of Orthobiologics, there's PRP Now, which is just a self-paced clinical start, Orthobiologic Practice Launch System, which is a done with you launch system, TrueMD, which is a full transformation, and then a Clarity is just a personalized strategy day with me to really figure out where to position, how to position, what your bottlenecks are one-on-one. So I wanted to just thank you, Doug, so much. It was amazing. I want to thank everybody for joining this. This was great fun and so educational. Oh my gosh, my brain is exploding. I love it. And these are some QR codes if you want to look at the programs, book an authority call and talk it through, or just take the readiness assessment. That would be perfect. We are at top of hour. If there's any questions, please pop them in the Q&A. And we'll be respectful of our time here. We'll make sure that we see all of the things. There are a couple of questions, yes. So if you don't, and it's from the illustrious John Kanab. Quote of the month, this is why it's called back surgery, because patients keep coming back. Classic, so true. He did have a couple of questions. The role of SPECT CT in terms of specificity for discogenic pain.
Yeah, so very high in terms of specificity. So not the best in terms of sensitivity because you have to have enough bone turnover for the radiotracer to light up. But if it does, you can bet your bottom dollar that's active bone turnover and usually a surrogate for degenerative end plate changes. So it's excellent.
Awesome. And then finally, he says, I love John Kanab. He's one of my great friends, and he's very transparent. He says, I've done plenty of unintentional intradiscal steroid injections during infraneural TFEs and have never had an infection, but there's case reports of discitis, usually at the second or third round, not the first. Does putting Gent 500 micrograms per cc into the disc at the time of a steroid eliminate that risk?
So John, let me kind of give you what we typically do. So I don't put Gent, unfortunately, I lived through the days where we used to put amikacin into the disc or the bone cement that we would mix, but it's toxic for the nucleus pulposus cells, as is higher concentration contrast. And so I use Dex and 2% or 4% preservative-free lidocaine. And the risk of discitis is negligible. So the Viadisc has 19,000 cases in it, the registry, zero discitis. Believe it or not, I have never knowingly had a discitis, never. And I don't use the double technique. I use a single needle technique, and I use antibiotics on everybody. The concoction I mentioned earlier, but it's all intravenous. And I don't think you need to mix it into the disc. Anytime you access the disc, just use IV antibiotics. And I think the rate in the formal measured rate of a discitis out of a Dutch paper was 0.24%. So even that, which I think is high based on, in addition, all of our clinical trials put together as an amalgam that I mentioned have had zero discitis cases. So I think that's just something I really wouldn't worry about it.
While using IV antibiotics.
Yes. Okay. So anytime the disc is accessed, IV antibiotics.
And how long do you run them before, to make sure they're in circulation? Because you don't want to be like, oh shoot, we're in the disc. Whoops.
No, you can do them just perioperatively. I just do them just before, but you can do them during the procedure, just to give the sedation, give the antibiotics, and it doesn't appear to make any difference. I mean, there's so few discitis cases, and I've never seen one, and so hopefully that's encouraging to you.
Yeah, so there is, in the regenerative medicine world, there is some conversation about intradiscal PRP or intradiscal BMC and, the risk of discitis. Now, in my thought process, is it really discitis, right?
No, so there's a couple
thing.
Yeah, there's a couple things there. I mean, there's such thing as a inflammatory non-discitis that looks exactly like discitis. And in Luigi Manfredi's book, Tim Davis and I wrote a whole section about this inflammatory non-infectious discitis, because you can see this and has an in-plate erosion, looks like a discitis, acts like a discitis, but when you biopsy it, you culture it, there's nothing there. And the key to it, to avoid biopsying an inflammatory disc, is you look at the inflammatory mediators. And the sed rate and the PRP are normal or near normal or just barely elevated. In a real discitis, those things will be sky high. So this is kind of how you separate the two. So there's, Arnold Kaplan said these cells have no MHC complex on them and are immunoimmune. And then he changed it later. He said, well, they're probably more immunoevasive. So sometimes the cops catch these cells and they catch them and the macrophages have an activity and it looks like a discitis. So they're not completely immunoprivileged, or they're more immunoevasive.
And then, I know we are over time, so thank you so much. But there's this concept about the fact that the disc is not sterile and that there is a microbiome.
Right. There's a microbiome in the disc, absolutely. So I mean, it's not sterile. It's about the microbiome. It has far fewer places like the gut or the mouth, but there is a microbiome in the disc, absolutely. So I think that's something good to know, and as you go in, something else that's really good to know and comforting is that injections with some form of MSCs or whatever you want to name those, signaling or stem cells with certain degree of stemness, those are actually antimicrobial. And the same guy, Hydrogels, used to treat osteomyelitis with MSCs. So I mean, this is right. I mean, it's true. Let's go in.
Yeah.
And so I think there's some inherent antimicrobial action with at least cellular regenerative therapy.
Yeah. When I grow up, I want to be Philippe Hydrogels.
Oh man, I know. Published 30-year data.
Right.
That'd be awesome.
Well, Doug, thank you so much. John, I hope your questions are answered. Those are great questions, and I really appreciate your time. Thanks everybody for sticking with us. It was a fantastic talk, and I'm going to have you back, and we're going to have to do this again.
Absolutely. You're really great to be with you.
Awesome. Thanks so much, everybody.